Hello, everyone, and welcome to today's virtual Thalassemia Grand Rounds. This Grand Rounds is a partnership between the Cooley's Anemia Foundation and the Division of Blood Disorders at the Center for Disease Control and Prevention, also known as the CDC. I'm Dr. Farzana Sayani, and I direct the Penn Comprehensive Adult Thalassemia Program and Sickle Cell Program at the Hospital of the University of Pennsylvania. I'm also an assistant professor of medicine at the Perelman School of Medicine at the University of Pennsylvania. I'm delighted to be with you today for these rounds. Today, we will take a deeper look into the management of non-transfusion dependent thalassemia, NTDT. We're grateful to the Cooley's Anemia Foundation and the CDC for the provision of continuing education credits in the form of CME, CNE, and CEU. Instructions for receiving these credits will be provided at the conclusion of today's presentation. Before I introduce our guest speaker, I'd like to go over a few helpful tips for participating. Upon joining, you would have seen two audio options. You can opt to listen via the speakers on your device or by using your phone to call in. If you choose the phone option, the GoToWebinar toolbar will provide you with the phone number, access number, and audio PIN number that you will need. All audio will remain muted throughout the presentation. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area under the toolbar. We will respond to as many questions as time allows. Today's rounds will last approximately 1 hour. Please note that these rounds will be recorded and made available for future access. These are the disclosures. The learning objectives for today's presentation will include description of the pathophysiology, the complications. We'll also discuss treatment and management options, and then also strategies to improve care coordination and outcomes in non-transfusion dependent thalassemia. So we'll start off with a few pre-test questions. So the first pre-test question is now on your screen. Which measure in an NTDT patient indicates that iron chelation therapy should be initiated? Please select your response. Thank you. We'll now move on to our second question. Which of the following is true about transfusions in NTDT? Please select one of the following. Great. Our third question, which of the following is not typically associated with NTDT? Our fourth question, which of the following is inaccurate about NTDT? And our final question, which of the following describes the most appropriate approach to transition of care for patients with NTDT? Thank you very much for participating in that section and helping to answer those questions. So before we begin our rounds, let's take a look at a case study that illustrates several key concepts in the management of NTDT. Please keep this case in mind since we will discuss this later at the end of our presentation. So this is to introduce Mr. S, who's a 36-year-old man with a history of hemoglobin E beta 0 thalassemia, but no hematology follow-up in over 5 years, who's presenting to the emergency department with a 5-day history of increasing back pain and lower extremity numbness. He also complains of fatigue and intermittent palpitations. His baseline hemoglobin is around 7 to 7.2 grams per deciliter. He's not on any chronic transfusions, but received about 1 to 2 transfusions a year as a child. His surgical history is significant for a splenectomy and a cholecystectomy at 12 years of age, and he's not on any medications. On physical exam, he appears thin, his BP is 100/70, his heart rate's 98, his O2 sats are 95%, he has scleral icterus, he has maxillary prominence. You also note hepatomegaly, there's bilateral lower extremity weakness and numbness. His key laboratory findings for today's discussion include a hemoglobin of 7, an MCV of 62, a normal white blood cell count, and a platelet count of 680. He has normal renal function tests, and his liver functions show an elevated bilirubin at 3.2, direct bilirubin is normal, AST that's 2 times the upper limit of normal, and an ALT that's normal. His ferritin is also elevated at 825. So what are the concerning findings in the presentation of this gentleman? And now it is my pleasure to introduce today's presenter, Dr. Ashutosh Lal. Dr. Lal directs the Comprehensive Thalassemia Program and the Iron Disorders Program at UCSF Benioff Children's Hospital in Oakland. He's also professor of pediatrics at UCSF School of Medicine. Welcome, Dr. Lal.
Thank you, Dr. Sayani, for the introduction and a very interesting case presentation. So the format of the talk today is to introduce the concept of non-transfusion dependent thalassemia as we understand it in today's times, and then go through some of the pathophysiology complications and recommendations for management. After we've gone through this, we will return to the case and see what we can apply from the facts presented in the presentation. It has been traditional for the past decade or so to look at thalassemia syndromes along the continuum of how much transfusions are needed, which is a proxy for the severity of anemia. So we can look at the thalassemia syndromes across the continuum of severity, from no transfusions, occasional transfusions, and regular transfusions. And I would suggest that we differentiate between regular transfusions that are given to control symptoms versus those that are necessary for survival. And in this setting, we would then see how we can classify thalassemias, leaving aside trait. Patients who need no transfusions or occasional transfusions are grouped under NTD, and those who require either regular transfusions for symptoms for survival are transfusion dependent. And what is notable is that the transfusion dependent group is actually a heterogeneous group as is the non-transfusion dependent group, because of the severity of anemia is different. The more traditional way has been to look at thalassemias as either intermediate or as major. And this traditional classification, the word thalassemia major is often used for the prototypical infant who is born or soon after birth will develop severe anemia and will require transfusions for survival within the first year or 2 years of life. Everybody else gets classified as thalassemia intermedia, but many of those patients would then require transfusions for symptoms. Within this classification, we can then place the beta thalassemia diagnoses, beta thalassemia intermedia and E beta thalassemia. Some of these patients require no transfusions, occasional transfusions, or regular transfusions. And of course, beta thalassemia major patients require regular transfusions. The same thing can also be done for the alpha thalassemia syndromes, where the deletional hemoglobin H patients don't require transfusions. Those who have non-deletional or other forms of mutations may require occasional transfusions, sometimes regular transfusions. And then there is a group of severe thalassemia syndromes, alpha thalassemia syndromes, which are not a topic of today's discussion, that require regular transfusions for survival. So within this framework, can we define a hemoglobin range where we can say that the patient has thalassemia intermedia? And the only place where we have consensus between all the groups is that if you have 2 beta thalassemia mutations and a hemoglobin of less than 7, then everybody should be on transfusions. With E beta thalassemia, there's more uncertainty. And sometimes even patients who are less than 6 grams may not be on regular transfusions, though we would recommend that 6 be taken as a lower threshold for starting transfusions in everybody, irrespective of symptoms. And then for alpha thalassemia syndromes or hemoglobin H disease, it's very uncommon to have a baseline hemoglobin less than 7, and that probably portends a more severe genotype than we're usually accustomed to looking at. So even though we have these lower thresholds, there are patients who may have severe symptoms and may require transfusions to start, even when their hemoglobin is above that threshold. And that can extend to up to 9 and sometimes even higher. At the upper end are the milder syndromes, and there's a line of uncertainty where we would say that we suspect the patient may have thalassemia intermedia and not thalassemia trait. And that is especially the case with the beta thalassemias, where the fetal hemoglobin response sometimes can be so robust that the total hemoglobin can be 12 or even higher. So in these cases, we at least at a minimum should see some evidence of hemolysis or infective erythropoiesis, and we would need a compatible genotype to say that the patient has Morgan trait. So what are the severe symptoms we're talking about? And we'll return to these later on also. These differ between infants and children and in adults. In children, growth is the central feature. So any growth failure would be considered a severe symptom. There's also the issue of skeletal facial changes, and then splenomegaly, especially large spleen or a rapid enlargement of the spleen. On the adult side, it is mostly the development of complications, such as extramedullary hematopoiesis, cerebrovascular complications, thromboembolic complications, pulmonary hypertension, leg ulcers, osteoporotic fractures, and of course, poor quality of life, which leads to a decline in the work capacity or usual activities. What I would like to emphasize is that the occurrence of these symptoms indicates there's excess long-term morbidity if transfusions are not initiated. And in some of these complications marked by these asterisks here, regular transfusions are needed urgently to prevent disease progression. So we begin our discussion with genetics and pathophysiology. And the genetic basis of the mutations that underlie thalassemia are responsible for the tremendous phenotypic diversity. We'll look at beta thalassemias, we'll look at alpha thalassemias, and then we will also pay attention to what are the non-genetic factors that influence the phenotypic diversity. Let's first start with beta thalassemia. And this depicts the pathophysiology of beta thalassemia. And we have known this for a long time, that the central issue in thalassemia is the imbalance in the chain synthesis, globin chain synthesis. In the case of beta thalassemias, the beta chain synthesis is either reduced or completely abolished, which leads to an excess of alpha chains that denature, degrade, and cause hemolysis, as well as ineffective erythropoiesis and anemia. And then the gamma chains are available to combine with the alpha chains to produce hemoglobin F, but they occur at a variable rate. Some have less, some have more. So the issues that affect the severity are how much surplus of alpha globin chains is there. And the second issue is how much of beta and globin chains are available. So within this framework, then we can see that there are three things that affect the severity of disease. First is the type of beta mutation. And in this picture of representing the beta globin gene, there are specific areas along the gene where the mutations cause only a mild reduction in the beta globin synthesis. And these include some well-known mutations such as the E mutation, the IVS1-6 mutation, and the mutations in the 3' end. These can often be associated with milder beta thalassemia syndromes. The other thing is that the excess alpha chains can be abrogated if one or more alpha globin genes are deleted. And this can happen with co-inheritance of alpha thalassemia. And finally, and quite important, is that there could be an increased availability of gamma chains due to persistent synthesis of gamma globin. And this can occur either as hereditary persistence of fetal hemoglobin or due to the co-inheritance of certain quantitative trait loci that maintain higher hemoglobin F, higher gamma globin chain synthesis. Just to emphasize the importance of these quantitative trait loci, I would like to present this data from a study from Italy that looked at patients who had homozygous beta 0 thalassemia and then determined what is the phenotypic variability or the severity of anemia within a group that does not produce any beta globin chains. And what they looked at was the effect of how many favorable characteristics, either as hemoglobin F QTLs or the deletion of alpha chains, alpha globin genes was present. And this study demonstrated convincingly that the distribution of these favorable quantitative traits determines the severity of anemia and when transfusions are initiated after birth. So if a child inherits none of the favorable traits, then they have a very high rate of starting transfusions very early in life. And at the other end are patients who have multiple favorable traits, and many of them don't start regular transfusions. Here it shows half of the patients have not started transfusions, even when they are 10 years old or more. And this is a condition that has also been referred to as homozygous beta 0 thalassemia intermedia. On the alpha thalassemia side, we have to consider both the fetal and the adult life, because alpha chains, which are deficient in alpha thalassemia, are needed for both the fetal life and the adult life. In fact, the onset of alpha thalassemia would start towards the end of the first trimester. And that happens because the only limited amount of alpha chains are available to combine with the gamma chains in the fetus to produce hemoglobin F. And all the unattached chains, the excess of gamma chains forms hemoglobin bars. After birth, the gamma is replaced by beta, and now the excess of gamma chains is replaced by beta 4, which is the hemoglobin H, giving the disease its name, hemoglobin H. And the hemoglobins, unfortunately, do not participate in oxygen transport. And this causes considerable hypoxia, erythropoietic drive, as well as hemolysis and ineffective erythropoiesis. So if multiple different mutations that can happen or deletions that happen within the alpha gene locus give rise to many different combinations of what we would call hemoglobin H disease. But the hemoglobin H disease, the underlying hemoglobin H disease, is a tremendous number of different syndromes which can be grouped into homozygous non-deletional, deletional hemoglobin H, non-deletional hemoglobin H, and then hyper unstable alpha variants, and some rare forms of alpha thalassemia. So on the non-genetic side, there are other things that influence how thalassemia manifests phenotypically. And this includes, first of all, hemoglobin composition. And the reason behind this is that the various beta thalassemia syndromes will differ in the proportion of fetal and adult hemoglobin, and some patients may have hemoglobin E when they have E beta thalassemia. Now, hemoglobins A and E have favorable oxygen transport compared with hemoglobin F or BARTs or hemoglobin H. So this affects the adaptation to anemia, and also other things that are seen at this age are that there is a diminished erythropoietic drive in adults versus children, but that is offset by an age-dependent decline to tolerance to anemia and the development of complications with age in thalassemia intermedia. Spleen is an important player in all of this, and when the spleen size enlarges and hypersplenism occurs, then that can lower the baseline hemoglobin. And if the spleen is taken out, then that alters the risk of many different complications. Finally, environmental influences such as recurrent infections and nutritional deficiencies can also alter the presentation of thalassemia. We will focus on clinical complications in thalassemia intermedia, and hopefully we'll also illustrate how these complications differ from what we traditionally know in thalassemia, in transfusion-dependent thalassemia. So in this data taken from the paper by Dr. Taher from 2010, lists down here the various complications that are present in thalassemia, in non-transfusion dependent thalassemia, mainly to illustrate the fact that most of the complications are age dependent. For example, the occurrence of pulmonary hypertension, heart failure, thrombosis, leg ulcers, and many others is predominantly seen after the age of 35, and the risk is higher in the 18 to 35. And really very few, it's much less common in children. We can group the complications into some categories, and the first one is the complications that are related to anemia itself. Now, I apologize. Okay. So, so the first group of complications is related to anemia itself. And in this group are things such as need for transfusions, the development of alloimmunization, and enlargement of the spleen. Now, the transfusions in non-transfusion dependent thalassemia can be intermittent or they can be regular transfusions. The intermittent transfusions are needed for three common reasons. One is the occurrence of infections or febrile episodes, which can cause an acute drop in hemoglobin level. During surgery, because these patients have lower baseline hemoglobin levels, are more likely to get transfused. And the third is during pregnancy, as the baseline hemoglobin falls towards the end of the first trimester, many patients with moderate to severe forms need to be supported. Regular transfusions are needed due to the occurrence of severe symptoms or due to the development of complications and deteriorating quality of life in adults. On this side, we see a history of a child with hemoglobin H constant spring who required 4 episodes of transfusions due to febrile infections. And in each of these episodes, the hemoglobin level dropped to below 6 grams per deciliter. And what is important to see also is that there was an increase in the bilirubin level, which spiked during each of these episodes, indicating more hemolysis. And at the same time, the reticulocyte count plummeted even before the transfusion was given. So indicating a combination of increased hemolysis and suppression of the bone marrow, which can cause a sudden and rapid decrease in hemoglobin levels. So the second complication is that of alloimmunization, and I would think that this is the most significant complication of transfusion therapy in non-transfusion dependent thalassemias. The alloantibodies can develop very early and can be multiple, and they're not protected by having an intact spleen. Especially during pregnancy, the risk of developing antibodies is very high, and this can lead to potential fetal harm from hemolytic disease. And in thalassemia intermedia, there's also the added concern of delayed hemolytic transfusion reaction. So in this study by Yang et al. Shows the risk of developing red cell antibodies with the number of transfusions and the much higher risk in non-transfusion dependent thalassemia who were given non-antigen matched units compared with transfusion dependent thalassemia patients given non-antigen matched units. I wanted to illustrate an example of antibody evanescence, which is the disappearance of antibodies with time. This is a patient with beta thalassemia intermedia who started off with a prior transfusion reaction history, but with the negative antibody screen, given a transfusion and developed a delayed hemolytic transfusion reaction, and then a persistent positivity for the anti-Duffy-B antibody, which on serial follow-up, when transfusions were continued with matched red cell units, the antibody screen eventually became negative again. And this shows the risk of patients developing DHTR if they are transfused in multiple different institutions and a complete transfusion history is not available. The third complication is that of splenomegaly, which, as we know, if increasing spleen size will worsen the baseline hemoglobin level and the patients may become symptomatic because of that. We think that the rapid enlargement of spleen really indicates severe disease. And this underlying severe pathophysiology is not altered by just simply by removing the spleen. And if the spleen is removed, then many long-term complications are increased. So what is the alternative to that? How one should approach a patient who has an enlarging spleen? So this is a child with E beta thalassemia, and for the first several years, the spleen size has stayed stable, but after 7 years, the spleen size starts to go up. And eventually, so that also leads to a decline in the baseline hemoglobin level. And when this child is started on regular transfusions, the spleen size regresses quickly. So chronic transfusion therapy offers an alternative to doing splenectomy in the presence of rapid splenic enlargement, and is probably a safer option in the long term. So it was talking about the effect of splenectomy and the risk of long-term complications. And this illustrates in the paper from Dr. Tahir, is that patients, they have compared several hundred patients who either did not have splenectomy or underwent splenectomy. And most of these complications that were detected, whether pulmonary hypertension, heart failure, thrombosis, cholelithiasis, and so on, were many times more common in patients who had undergone splenectomy. Now, in this group of patients, there were some patients who were considered to be symptomatic and got started on transfusions. So what was the impact of starting transfusions on long-term complications? And that is illustrated here. So these are patients with NTD who were deemed severe enough to require transfusions. And in red are patients who were on regular transfusions, and in blue who were not given regular transfusions. And all of the complications, the rate of the complications is considerably lower if regular transfusion therapy is instituted. The second group of complications we want to talk about are those related to hypercoagulability and the vascular complications. And this is because the red cells in thalassemia are abnormal and contribute to hypercoagulability. And if the patients are splenectomized, then there is also more thrombocytosis, and there's evidence of endothelial injury, and multiple different sites of thrombosis can develop. The first one, and the very concerning site, is the cerebrovascular disease. Multiple different abnormalities have been described: like stroke, arterial stenosis, Moyamoya syndrome, and white matter changes that are shown here. The long-term impact of some of these changes is not clear, but is very concerning about the severity of the disease itself. And the risk for all of these complications is increased by splenectomy, as I've mentioned before. The second is of leg ulcers, and shown here in this patient who had indolent chronic leg ulcers in severe beta thalassemia intermedia, and the response to just 3 to 4 months of regular transfusions. And if these are not treated, they can have a very severe impact on the quality of life of the patients. The other serious complication, vascular complication, is that of pulmonary hypertension. And it is a characteristic long-term complication of non-transfusion dependent thalassemia, where pulmonary hypertension can lead to right heart failure. This has been known for over 35 years now, and described in many different forms of non-transfusion dependent thalassemias. There's an increase in pulmonary vascular resistance, and the prevalence of pulmonary hypertension depends upon what age of patients is studied and what group of patients is studied, but in some cases it's been described as high as 70%. We suggest screening with echocardiogram, and if a patient has a tricuspid regurgitant jet velocity more than 3, then that should be a cardiology referral and consideration for cath. On this side is a paper from patients from Greece, that shows that the occurrence of tricuspid jet velocity, which is in the abnormal range, goes up with age. And there are some patients who present with heart failure who have extraordinarily high pulmonary artery systolic pressures. It's illustrated in one of patients that we followed who presented with very high pulmonary artery pressures and in heart failure, and then responded to the start of red cell transfusions and specific therapy against pulmonary hypertension. The third group of complications is that related to iron overload. In this, there is initially a sense that despite recent improvements, there is still an under-recognition of iron overload in the non-transfusion dependent thalassemia patients. It has become more clear that the gastrointestinal absorption of iron is increased in non-transfused patients because they have hepcidin insufficiency. So that iron overload will develop even if a patient has never been transfused before. But if patients also receive intermittent transfusions, then that will exacerbate the iron overload quite a bit. So screening for all patients is recommended irrespective of transfusion history. The one thing that is characteristic of this group is that serum ferritin will underestimate the liver iron concentration. And if you take the ratio of serum ferritin to liver iron concentration and compare that to sickle cell disease or transfusion-dependent thalassemia, patients with non-transfusion-dependent thalassemia have much lower ferritin levels for any given liver iron concentration. So there's some differences in how iron loads in transfusion-dependent and non-transfusion-dependent patients. Liver is the primary site. Splenectomy increases the level of plasma non-transferrin-bound iron. So it is, we have adopted and recommended, along with other groups, that patients be screened with serum ferritin. And if the serum ferritin is more than 300, there should be evaluation for liver iron concentration. It is true that the extrahepatic iron deposition is less common in non-transfused patients, but there is a group that should be screened for cardiac iron and pancreatic iron if they meet some of these criteria for severe iron overload. Iron overload has been associated with liver fibrosis, cirrhosis, and hepatocellular carcinoma. And finally, I will just quickly list the other complications that we talked about. Liver disease, there's a gallstone and gallbladder disease and can cause acute pancreatitis in some patients. There's osteopenia and bone disease, which can be very concerning, can lead to pathological fractures. And then there is extramedullary hematopoiesis, about which we will talk about later on. That can happen in multiple locations and can cause permanent neurological injury if left untreated. In a very recent publication by Dr. Musalem, their multi-center database was created, and that looked at the causes of death in 2,000 patients with NTD. And there were 113 deaths. The causes of deaths are listed here. And I want to point out that majority of the deaths were related to either heart disease or to liver disease. And the causes of heart disease were only very rarely related to deposition of iron in the heart. In majority of cases, it was listed as other cardiomyopathy or as pulmonary hypertension related deaths. In the liver, patients either develop cirrhosis or hepatocellular carcinoma. From the same paper, we can look at the effect of mortality of whether a patient is transfused or not transfused. So patients who are symptomatic, have non-transfusion dependent thalassemia but are symptomatic, if they get started on transfusions, that's listed in green, and those who are not transfused are listed here in red. So if you look at all-cause mortality, then by 50 years, the curves diverge significantly, indicating that survival in patients, in symptomatic patients who are not started on transfusions is significantly worse. And a lot of that comes from cardiac disease. And the liver disease is more prevalent in patients who are iron overloaded, but they are not chelated. There is also a difference between the survival of patients who are followed in US and Europe versus Middle East and in Asia, indicating that management practices do influence how the survival of patients. So I want to end this section by saying that there is a lot of burden of disease due to variable in patients who have non-transfusion dependent thalassemia. And it has been estimated that the burden is comparable or may even exceed that seen in the transfusion dependent patients. But that leads many of our patients to start transfusions when they are adults because of very poor quality of life. But is there a way that we can identify these patients ahead of time who will develop severe complications and start them on transfusions? So in the section on management, we'll talk briefly about anemia, iron overload, and treatment management of some complications, and then care coordination. So the big question that comes up is how do we decide on which patient to transfuse or not? And that still remains one of the unsolved challenges. There are patients where we are clear about the decisions, and there are patients that are just on the borderline, and it's hard to make to understand whether the decision is correct or not. So I wanted to present our own data from our center for 25 years, where the others listed here are the non-transfusion dependent patients, were 322. And if one looks at just these patients, the non-Thal-major patients, and the different syndromes that comprise this group, patients who have beta-thal intermedia and E-beta-thal, significant percent of these patients get started on transfusions. But if you look at the alpha thalassemia syndromes over here, almost no patient with deletional hemoglobin H has received even a single transfusion, whereas the non-deletional patients are higher risk for intermittent transfusions, but only a few of them get put on regular transfusions. So there has been an attempt to develop consensus guidelines on when to transfuse patients with beta thalassemia, and this was published recently in the journal Transfusion. When you look at alpha thalassemias, though, from our own experience and that from other sites, we feel that deletional hemoglobin H patients, we should have strategies that will avoid the need for transfusions, whereas the non-deletional patients do require intermittent transfusions. And all of these patients who may need transfusions should have the availability of phenotypically matched red cell units. Hydroxyurea is an important drug in beta thalassemia intermedia. Its dose is lower than what is used for sickle cell disease. The mean response is 1.5 grams, but the response rate of more than 1 gram is seen in only 50% patients. And that is a problem that leads some of us to not use this medicine in other patients. But there are some indicators, genetic indicators, that show that patients who have some favorable polymorphisms respond better to hydroxyurea than others. The management of iron overload has been standardized, and deferricirox or gJeA is now approved for therapy, and these guidelines are based on the ones published by Thalassemia International Federation. We think that patients who have ferritins more than 300 should get a liver iron concentration evaluated, and if the LIC is more than 5, then the patient should be started on treatment, chelation treatment. We do have some optimism about therapies that are being developed now, and these include luspatercept. The recent trial shows that majority of the patients had a greater than 1 gram, and some patients have much higher improvement in their baseline hemoglobin levels. There are also other drugs in development, including pyruvate kinase activators, and there are others that have been tried. Some of them have worked and some have not. So we will talk about this a little bit on care coordination later, but I just want to say that non-transfusion dependent thalassemia patients are at much higher risk of failed care coordination as compared to the transfusion dependent patients. So the recommendations are to involve the patient caregiver in the development of the treatment plan and making sure that the patient develops health literacy to advocate for themselves. Transition of care is critical, as is the communication between the members of the core team and those with the extended team that includes several specialists. And if needed, there are many resources available to centers that see only a few patients with non-transfusion dependent health. So in summary, we are dealing with a very diverse group of disorders, which is placed under the label of non-transfusion dependent thalassemia. There are multiple complications. Many of these individuals require regular transfusions or will probably do much better if they get started on transfusions. And new treatment modalities are in development that are showing some early promise. And with that, I will stop and we will return to case presentation. And thank you for your questions that are coming in, and we will take them on afterwards.
Thank you very much, Dr. Lal, for an excellent presentation. I'm going to quickly review the case. So we've got some excellent questions I really want to try and answer. But just to quickly summarize, we initially had presented a 36-year-old man with hemoglobin E beta thalassemia with no real follow-up, who had come in with back pain and lower extremity weakness, had a baseline hemoglobin of about 7 to 7.2, had a prior splenectomy. Exam was significant for icterus, maxillary prominence, hepatomegaly, signs of extramedullary hematopoiesis, and most concerning was lower extremity weakness and numbness. And the ferritin was about 825. So the big question was, what was the concerning findings in his acute presentation? And we have several questions that come up that I'm hoping we can spend a few minutes to discuss. It's feel free to keep sending in those questions. So what are some of the concerning findings in his presentation?
Let me just start that, Dr. Sayani, by saying that before we delve into the medical complications, first of all, there appears to be a failure of access to care and to maintain availability of specialty care for this patient. And there hasn't been any transition of care, for example. And what are the barriers that this patient faced in establishing regular care for his thalassemia are worthy of our consideration. And these may be that there is less availability of adult hematology specialists who specialize in thalassemia. There may be insurance problems, there may be health literacy, and there may be other social, cultural, and many of these patients are in immigrant populations that may have linguistic and cultural barriers. So all of those are essential background to why this patient presented as this way.
Yeah, and these are, this might be the first time we see a person with non-transfusion dependent thalassemia when they come in with multiple complications. And I think we'd all agree that the main medical concern here would be a concern for cord compression for paraspinal masses from someone who has had a low hemoglobin, had an increased erythropoietic drive. We can tell that from facial features with maxillary prominence, the history of hepatosplenomegaly, and then also the low hemoglobins. And so this is what I think would be a key concern for the acute presentation.
So really the basis, the underlying treatment for just as for other complications, the occurrence of extramedullary hematopoietic masses that are presenting in this critical way is to start transfusions and hydroxyurea at the minimum, and then see, depending upon the acuity and the seriousness of the compression, whether a patient requires, some patients may require radiation in addition to that, although extreme cases may need surgery and laminectomy, but that is discouraged because the other treatments are usually effective.
Yeah, and the key is also with the transfusions is a hypertransfusion regimen where we're aiming for a pre-transfusion hemoglobin of 10, probably 10.5, especially in the acute setting.
It has been commented upon by some people that if you hypertransfuse somebody, then there will be a decrease in the blood volume as well as the amount, the erythropoietic drive, and that initial slight decrease in the pressure on the cord may in fact be like may save the neurological function. So even if one is preparing for the other treatments, the use of hypertransfusion and hydroxyurea should not be neglected. It's urgent.
Thank you. I do. We're getting lots of questions coming in. So I think I'm going to use the next few minutes to try and answer some of those questions, because I think in these cases we've the questions that the case brought up in terms of chronic management and prevention. I think prevention is really key, to prevent this acute complication of this particular case. I'm going to start off with a few questions. We talked about transfusions. There's one key point about splenectomy. So splenectomy is not recommended in most patients, but are there any situations when splenectomy might be indicated?
Yes, so there could be extreme cases where the spleen becomes so large that it will not decrease in size in spite of starting on transfusions, and the patient may be hypersplenic with severe thrombocytopenia, or there may be mechanical issues with pain and satiety and so on and so forth. Those are conditions where we would definitely, I think, splenectomy should be considered, but those are a small number of patients. I think in majority of cases where splenectomy is done, it could be an initial response to an increasing spleen size and fallen hemoglobin level. The other, I think, point to be made is that splenectomy patients who are at the highest risk for complications are those that are splenectomized and then are not transfused. These are the patients, just like the one in our case here, who present years later with development of a severe complication.
Yeah, and a relevant question that came up is how often in a splenectomized patient with NTDT or transfusion-dependent THAL, how often do you do an echo? Because we know there's an increased risk of pulmonary hypertension in splenectomized patients, especially NTDT. So how often would you do an echo to screen?
Yeah, our standard is to do annual echocardiograms, to specifically asking the cardiologist to look at the tricuspid jet velocity and any other signs of pulmonary hypertension or right heart strain.
Okay.
May I mention quickly that in alpha thalassemia, when splenectomy is done in alpha thalassemias versus beta thalassemias, the mechanism of pulmonary hypertension can be different. In alpha thal hemoglobin H constant spring patients, it's often chronic thromboembolic pulmonary hypertension that is more likely. So there, in those cases, it's the prevention everybody we think should be on aspirin, but it should be carefully monitored. And if patients have any thrombotic episodes, they need to be on long-term anticoagulation.
I think one of the really surprising findings, from your presentation and the recent data, is the risk of silent infarct and stroke. We don't think about that for thalassemia patients, right? We think about it in sickle cell patients. But the data from Dr. Tahar and a few other publications is that this is something to think about. So there was a question from the audience. So in a well-transfused non-transfusion dependent thalassemia, in a well-transfused patient, how often do you do an MRI? So whether they're transfused or they're in an NTDT patient.
Yeah, no, we probably wouldn't do it if the patient is regularly transfused, because that takes away the underlying pathogenesis for why these lesions occur due to endothelial damage or thrombocytosis or anemia and the watershed areas becoming hypoxic. Those are the driving pathogenetic mechanisms, and those are all taken away if your patient is started on transfusions.
I think for the, there are many adult patients who are still non-transfusion dependent. And especially for, especially for those who are severe, this has made me question, is there a role to do a baseline MRI of the brain to look for those silent infarcts, to look for moya, because if we think of underlying pathophysiology, if they've had low hemoglobins and a lot of hemolysis, is there a relationship with splenectomy? We're thinking of vascular changes. And it's something that I think about if we should do baseline in some of our adult patients, but again, we just don't have any data.
Yes, so there, what happens is that patients who have severe anemia may appear to have mild cognitive impairment, and we often attribute that to the slowness or in responding and other things, to the fact that they're severely anemic. I think these are precisely the patients who are at high risk for having these lesions, and I would definitely recommend doing an MRI in those situations.
Yeah. I had there's a question that came in about ferritin. So in an NTDT patient who has a normal ferritin, do you still need to do a liver iron scan?
No, you don't. So our different groups have made different thresholds for which ferritin level is concerning. So the ferritin level that's concerning is the one that will yield a likelihood of a liver iron concentration that is higher than the threshold for chelation. If the prediction is that the ferritin is 100 or 150, the likelihood that the liver iron is going to be more than 5 is pretty low. So we probably wouldn't do a liver iron MRI for liver iron in those situations. We've elected 300 based on some arbitrary experience-based reasoning, and I think it does depend on individual institutions. If they can do it for lower numbers too, but we think 300 nanograms per ml is reasonable.
Yeah, that's the same where we are as well. There was one regarding alpha thalassemia. So in a woman with alpha thalassemia trait, so cis, who's pregnant and her partner has alpha thal trait, so trans, does the fetus require any special monitoring or testing given the risk for hemoglobin H disease? This is very relevant in your practice.
Yes, so this is great. Thank you for bringing it up. Alpha thalassemia starts in fetal life, and as far as alpha thalassemia is concerned, birth is just a point along the timeline. But the manifestations can start in utero. Now, if it's a deletional hemoglobin H, which I'm presuming is what is being referred to as homozygous alpha plus thalassemia, and then the risk to the fetus is probably none. Even though fetal anemia will occur, and if you did an fetal ultrasound, some of the fetuses will have anemia, but it's not known to be to the extent that will cause high drops or any other problems. There are, however, non-deletional mutations that are well known to do exactly this. And I would mention a couple. One is the constant spring. So homozygous constant spring causes fetal anemia and high drops, which resolves after birth. And patients become quite well and non-transfusion dependent. And the other one is the polyadenylation site mutation, which is common in the Middle Eastern population, which can also do the same thing.
Mm-hmm. Excellent. There's one more last question I think we have, and I think that this is going to be relevant, is how extended phenotyping do you do in patients in person with NTDT? Yeah. When it comes to transfusions and reducing the risk of alloimmunization?
Right. So I think it's still reasonable to start with the RKTeE and the KEL. But increasingly, if the blood banks are capable of doing that, and with the creation of genotype donor registries, I think it may be reasonable at someday to also include the Duffy and the KID and the MNS antigens as well. And that can be done with the minimal increase in the workload on the blood banks once we have these genotype registries. Yes, because the first antibodies tend to be from RH and KEL, but that's not always the case. Every once in a while, we will see an initial antibody which is outside of this group.
Great. Well, thank you so much, Dr. Lal, for a great presentation, for answering these questions. Thank you to all of you for coming and joining us for this presentation, for all your excellent questions. We also would like to thank our colleagues at the CDC's Division of Blood Disorders and the Cooley's Anemia Foundation for this invitation to be with you today and for hosting today's rounds. If you have any additional questions about today's presentation, please contact either Craig Butler on the email address there or Cynthia Sayers on the CDC address there as well. This presentation will be archived and will soon be available on the CDC website as shown on the bottom of this particular slide. And finally, to receive continuing education credits, please take note of the direction on this particular slide. And there was a link as well that was presented in the chat box for that. With that, I would like to thank all of you for joining us today and engaging in an awesome discussion. Thank you, Dr. Lal. Thank you to everybody.
Thank you, Dr. Sayani, and thanks to the organizers for this opportunity.
Thank you. Good evening. Bye.
Bye.